Okay, thanks a lot. I appreciate the opportunity to present here today. I looked up on the internet to see sort of what the style of the talks are here, so I tried to go heavy on graphics and lower on text, which is difficult for an ASU faculty member. Mainly, I decided I'd look at one chart to spend most of the time here. I've been doing machine learning for a long time, and this chart appeared in the Journal of the American Medical Association last year. And it has a little bit of a summary and a history of the spectrum, as it's referred to, of machine learning. So it's sort of a question of, how much is machine learning? And really, I think that if you look at some work that people here might be familiar with, like the Framingham Cardiovascular Risk Score, that was developed in 1998. That is right about here, I think, on the graph. The graph has the data set size on the horizontal axis on a log scale, and it has sort of the amount of human to machine effort involved in the machine learning. And so the heart study, or the CV risk score study, was about in this region. A few thousand patients and, kind of moderate or modest computer algorithm. They ran a linear regression study. Is that machine learning? I would say it is. Over here, like down here, this is the Census Bureau data. So they've got, a few 100 million people in the Census Bureau data, and they've conducted some summary statistics there. Maybe less computer work, more data work here. It's kind of an interesting story. I'll make a point out of this in a minute. Down over here is clinical wisdom. Clinical wisdom may be based on anywhere from 1 to a few thousand patients, the number a physician can see in a lifetime. And so low on the computer side, but still widely used to this day. As we move up the scale a little bit over here to like number 10 or 11, we see some kind of notable, if you're in this field, these are rather notable. Netflix conducted a challenge a little more than 10 years ago now, where they asked people to build a movie recommendation system better than their current one. And what got people interested was they offered $1 million if you could do it better than they could. And that led to a lot of activity because there were teams that involved from high school students up to the machine learning lab at the University of Toronto working on this North American supercomputer network. So it was a rather diverse group that participated in challenges like that, but it opened up a lot of people's insight into what was possible with some of the algorithms. A team did win, but they probably earned a couple of dollars per hour for the amount of work and the amount of people involved in it. If we go over here, there's some maybe a little bit less known, but ImageNet, some of the, where's the Facebook photo tagger, you might be familiar up here with some of the newer neural network models that people have referred to. Chris just mentioned AlphaGo, that's right up here, number 6, fair amount of data. That's been surpassed already by AlphaGo 0, which is over here. And you kind of show, well, that's interesting. It doesn't use hardly any data. Well, that's because it plays against itself. And so this self-play is also an interesting concept that maybe has some role in healthcare as well, as we can maybe comment about. If we go up one more level, there's a lot more of that self-play in terms of these generative artificial neural networks that, again, are playing against each other at scale. One of the things that can be produced from that is this. This was what the adversarial networks produced when they played against each other. Now, had I known that was going to sell for $432,000 last year, I would have set up some servers. The prediction was it was going to sell for about $5,000. but they did quite a bit better than that. There's a lot of other help for applications, I guess we could say, for self-play other than computer-generated art. But that's for maybe another discussion. Our Center for Health Information and Research, I kind of think we sit in this area. We pool health data from a lot of sources around the state, things like the Medicaid administrative claims data, the ADHS hospital discharge data, administrative data, and electronic health records data from some data partners, for example. And so we tend to work in this middle space. There's maybe one other example I want to mention on this page, though, and that is the diabetic retinopathy project from Google in 2016, which is right here on this space. That's an interesting project. That's when the images are taken on the back of your eye when you go in for the exam, if you're not familiar with that. It's almost like a look inside your blood vessels in the back of your eye. And so those images are early warnings of diabetes, for example. And that's another reason why the periodic eye exams are useful, for example. If you've looked at those images, and I have in the past, we looked at algorithms for those. They're very difficult to discern the difference between diabetes onset and normal patients. But in typical Google manner, they do everything at scale. And so, whereas I had maybe 100 images, they went out and rounded up 300,000 to train their models on. They used a rather off-the-shelf model, and they clearly beat the current best humans on the diagnosis. So it's very easy for them to submit those in. One thing you notice about that problem, though, is it's rather narrow in focus. So that makes it a little easier for them to solve something like that, in that kind of domain. I spoke to one of the lead researchers on that project not too long ago. I asked him what was the most difficult part, and folks in the healthcare area can appreciate his answer. It was collecting the data. The rest was rather easy after that. There's a lot of buzzwords on that chart, so of course Dilbert's involved as soon as those come into play. And so that jargon issue always comes up in that space. But kind of a point or two from that is the following, is there's still a lot of work that needs to be done, we might say, in that mid-space on some basic health problems. And so this was the idea about the narrow focus versus the broader health problems that we need to address. So for example, what's the best primary care plans for asthma patients? And so that's a more open-ended question than something like the image thing. And we're hoping to work through the Cheer Center on addressing a problem like that. But maybe the way that's a little bit different these days is to kind of take this idea of self-play to some extent and just round up on as enough data as you could find from all over the country, from all different subpopulations, and take a look at what's working and what isn't. Collect the electronic health records, collect any claims data, collect the clinical notes, and go through that data and first of all identify what are the current management practices, which is not easy, right? Because EHRs, like, they don't just come out and tell you, well, this is the current management practice at this organization. So you have to sort of discern that from the data, maybe help it with some surveys and things, and then determine the outcomes, and then try and put that together. And then finally the project would finish with a randomized clinical trial, but at least in the beginning, it's more data-driven. I think we're going to see a lot more of this role of machine learning going forward in some of these broader scope, important problems that maybe haven't been able to be addressed before. And those technologies on that other screen will help here. The way that clinical notes will be processed is with deep neural networks. And so some of those are going to be used tactically in terms of problem solving in a domain like this. So there's a lot of opportunities there. And the goal there is to have at least 1 million patients in the study. And this is just one example of others, but I think we're going to be seeing more of these kind of studies going forward. I usually look at the Gartner hype cycles. If you're not familiar with this, I look at these every year. The hype curve this is time along the horizontal axis here, and this is the expectation of different technologies along this axis. And we could kind of cite a few of our favorite technologies here. Now, first of all, I don't always agree with everything on the curve, where it's positioned. And so there's nobody saying this is right. This is just one market research company's opinion. And just because you're in a particular place in the hype curve doesn't mean you're a bad technology. It just means there's a lot of expectations that have to be worked out before you're going to have the impact. And many things in the past have gone on to be extremely successful technologies. So I want to put that in as a disclaimer up front before we start disparaging any of these technologies. But this one is actually from 2017, and I'll tell you why in a minute. But if you notice, here's our machine learning here, right up at the top. And I got deep learning in there as well, right? Another kind of machine learning thing, right up there on the top, ready to fall down into the trough of disillusionment. I actually disagree with this. I think the hype is still building. I've been in this business for a long time. I would say the 1970s, and I have never seen this much hype. I mean, I was around when they were talking about microwaves running neural networks, and there was a lot of hype back then, but it had nothing like today. So I think it's still going up. But anyway, things will come down, and then they'll eventually come back. So some of your favorite technologies may be somewhere on the curve here. Some of them you probably haven't seen yet, or maybe you're not familiar with. What's the smart dust is just coming up next year. That'll be on the agenda, right? Deep reinforcement learning, that's one of my areas I'm working on now, so that's a little bit early. But there's quantum computing is coming on board on the hype circle. I think we're quite a few years away from that. But boy, that's going to change things quite a bit. Just a lot more processing power. And then some other ones are going down into the trough of disillusionment and then coming back again as we go forward. But why do you go into the trough of disillusionment? And I think we kind of have some pretty good opinions about that. And I think a lot of technologies fall in there, at least in healthcare, for the same reason. One is that, well, we've got to integrate them into the healthcare workflows. If they're not properly integrated, they're not really having the impact we expected as quickly as we expected. And so that's a major cause, I think, in my mind, of the trough. So we just have to realize that we have to build the tools so they integrate well. The other thing is that these exercises are not just one time, they're like journeys. Models get stale, right? They expire. We have to update them, we have to revise them, we have to put in the current data. Of course, in computer science, they got great names for this, right? They call it concept drift, right? So what your status of what you're modeling changes. Your process, your care, your current management practices are changing all the time. The models are built for one set of practices, and you have to keep them updated. And so that's another reason for the disillusionment. There's also the issue of the interpretability of the model. So on the top of that diagram that we first looked at, those generative neural networks, you don't have a clue how they're working. And the tool set to study how they're working being looked at, but it's a long way off. So the interpretability on those models is just about zero, at least from from an implementation point of view these days. And of course that causes problems, right? And so there's the model shade, as I call it, from a very clear, simple model like the CV risk score, that people can look at the regression equation, all the way up to the black box models that are much more difficult to interpret. That doesn't mean that any of those models are bad or not useful. It's just that we have to realize that the scale, right, causes effects for the zone of dissolution, the trial of disillusionment on the charts. Well, I do think that data is important, though, because otherwise we wind up in this kind of scenario. And I always say, well, I'll go with my opinion if we don't have data to be based it on. And so there's still a lot of opportunity here. Particularly, I think my main point is in that mid-sector, broader, more difficult problems for artificial intelligence to help. And I think some of the other speakers will talk about other toolkits in those spaces. And so I'll stop there. Thanks.